This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to this episode of the Neurology podcast. My name is David Perez. I'm a neurologist and psychiatrist based at the Massachusetts General Hospital. Today I have the pleasure of speaking with a friend and colleague, Glenn Nielsen, a physiotherapist and functional neurological disorder expert with a background in neurology. Glenn is based out of St. George's University Hospital and City St. George's University of London. Glenn and colleagues have published a landmark paper in the Lancet Neurology titled Specialist Physiotherapy for Functional Motor Disorder in England and Scotland, a pragmatic, multi-center, phase 3 randomized controlled trial in May of this year. Glenn, welcome.
Hi, David. Thank you. Thanks for inviting me to talk about our trial.
To start us off, tell us, why was this trial in the motor variant of functional neurological disorder performed, and why was it important?
It's generally widely recognized that people with functional motor symptoms and FND, that they can do well with physiotherapy. But up until recently, there's been no evidence from large randomized controlled trials. So this is a problem because it makes it difficult for people to access treatment because funding is often not given. I guess another reason why it's important is because physiotherapy is recognized as part of multidisciplinary treatment for FND. But what a physiotherapist should do is not well documented, and we have no data to base those decisions on. So over the last 10 years or so, within my collaborative group, we've been developing approaches to physiotherapy and working up towards testing them in a randomized controlled trial.
Tell us about the inclusion and exclusion criteria that you all used.
Our inclusion criteria were adults with functional motor symptom, and they needed to have completed their clinical investigations. They also needed to be accepting of receiving physiotherapy for FND. We didn't stipulate that they needed to be accepting of the diagnosis of FND. So they just needed to be happy to receive the intervention. With regards to our exclusion criteria, we excluded people who had very severe coexisting problems that would prevent them from being able to engage with a physiotherapy, an outpatient physiotherapy program. So very significant psychiatric problems such as anxiety or depression, very severe pain or very severe fatigue. And just to be very clear, these weren't absolute exclusion criterion. They were only excluded based on these criteria if the neurologist who recruited the participant felt that they would prevent them from being able to engage with physiotherapy. So as an example, if somebody had very severe pain, they attended a physiotherapy session and then their pain was so severe they weren't able to attend for another couple of days because they were in too much pain. When we applied those criteria, what we found was about 40 to 45% of our patients had rated their pain and fatigue as severe or extreme. So it just shows that we weren't cherry-picking our participants. They ranged the spectrum.
And you've been a pioneer, you and your colleagues, in developing this neurophysical therapy approach to patients with functional motor symptoms. When you say specialist neurophysiotherapy, what exactly do you mean?
We do a specific intervention that's targeted towards functional neurological disorders. Or I suppose we're trying to target the mechanism that drive the symptoms. So specifically, probably the most important thing we mean here is attention. So functional symptoms and functional motor symptoms are exacerbated when the person's their own attention is directed towards their body, when they're overly aware of their body and their movement. The symptoms get worse. So our intervention approach involves movement retraining that helps to teach the patient ways to externalize their attention to improve their movement. Another thing we try and do is think about this predictive brain model of functional symptoms. So this idea that expectations can drive the symptoms as well. So with our physiotherapy strategies, we're trying to facilitate normal experiences of movement and also demonstrate to the patient their own normal movement using mirrors and video feedback. And through this, we're trying to change their expectations about movement. Or another simpler way to think about this is improve their confidence that they can move. So these are things that are a bit more specific to FND. And while I think of it, other things are that we might address specific common problems associated with FND, such as persistent pain. The biggest component of treatment, really, or as big as movement and training, is education. So we include a specific education about functional motor symptoms component to our treatment. And we use a specific symptom explanatory model to help patients understand their diagnosis and understanding what they need to do to improve their movement. So this is what we've developed over the years and calling, for want of a better term, a specialist therapy approach.
Now tell us, what was the design of your clinical trial?
It was funded by the UK's National Institute for Health Research. And as with most of the trials in this area, it was a pragmatic trial and it was conducted within the context of the UK's National Health Service. We aim to randomise 300 people and compare our specialist approach to physiotherapy. And our control condition was treatment as usual physiotherapy. So in the UK, probably most people can get access to some physiotherapy. Often it's within a neurorehabilitation team, and the patients were recruited from neurologists and randomised either to the specialist approach, or for the control, the neurologist would refer the patient to a neurophysiotherapist in the community. But in the UK, the quality and the amount of physiotherapy a patient would get in usual care would differ vastly, and we knew that was going to happen. So some of our control participants would have gotten very good treatment, and some of them may have had very limited treatment. And because we have a pragmatic trial, I guess what we wanted to show is that a more specialist, thorough approach to treatment was better than what was currently happening. We followed our patients up with the primary outcome, which was the SF-36 physical functioning domain. And this was, the primary outcome was assessed at 12 months, but we also did a 6 months assessment.
Were these the results that you all expected and hypothesized, or were there some surprises here?
The official answer is we start a trial from a position of equipoise, and we don't know which is better. But of course, we had somewhat expected there to be a better result for specialist physiotherapy. The trial was statistically powered to detect a 10-point improvement in the specialist physiotherapy group over a control group. We didn't get that, which was disappointing, but I think we got a good, honest result. So I think what we found is that the specialist physiotherapy group wasn't better than usual care physiotherapy at improving physical function. But although we're not statistically powered to detect these changes, I think our data suggests that specialist physiotherapy was better than usual physiotherapy at improving other domains of change. So the patient perception of the severity of their motor symptom and some of the mental health domains and self-efficacy. So it was a bit of a surprise. I think it shows actually that both groups improved. We don't in this trial have a no treatment group, so we can't say that improvement isn't unrelated to regression from the mean or towards the mean. But I think there is probably data there that shows that physiotherapy from either group probably was helpful for the patients with functional motor symptoms.
You've done quite a bit of work with colleagues internationally on consensus recommendations for physiotherapy and functional motor symptoms. And there's been a sea change over the past decade or so in the use of those consensus recommendations to really inform outpatient physiotherapy care. What role did this play potentially in how you thought about the usual care treatment arm?
We did a feasibility study which replicated the interventions for the current study a little over 10 years ago, I think. And in the feasibility study, we found that treatment as usual 10 years ago didn't improve on the SF-36 nor on the CGI very much at all. But in this study, the participants in usual care did improve. And what we did actually, we spoke to every participant and conducted an interview to ask them what their treatment included. And we found evidence that the usual care physiotherapy, many of them got, or perhaps at least around 60% of them got, elements of treatment that we would consider to be good treatment and that are described in consensus recommendations for physiotherapy for FND. So we think that although the treatment as usual group had fewer sessions compared to the specialist physiotherapy group, a substantial proportion of them actually got good treatment, which wasn't the case in our feasibility study.
What are the clinical implications here, Glenn?
The first thing that I think is important and the most basic thing was that physiotherapy was a safe intervention. So I don't think people necessarily thought that 10 to 15 years ago. But what we found in our trial is that our participants had complex problems and complex multi-comorbidity. A significant proportion actually had hospital appointments or hospital attendances, overnight stays in hospital related to other problems or related to their F&D. But none of these problems were related to physiotherapy. And we didn't find any serious adverse events that were related to receiving physiotherapy, despite it being a group with complex problems. So I think that's the first thing we can say. The second thing we can certainly say is that the participants in our trial really highly valued physiotherapy. So in both groups, they rated their physiotherapy treatment and the person who gave them physiotherapy very highly. They were very satisfied with treatment. And satisfaction was a little bit greater or significantly greater for the specialist physiotherapy group. And although we can't say that specialist physiotherapy was better than usual care physiotherapy at improving physical function, I think we can say that both groups did improve from baseline. And although we're not powered to detect differences in our secondary outcome, there were additional benefits in specialist physiotherapy, which may relate to other benefits, perhaps benefits beyond the 12 months follow-up, and also benefits related to health economics. So we'll be publishing our health economic outcomes soon, which show some interesting and promising results.
Say more about that. You've collected a rich set of data with a very well-performed study. I should highlight, also conducted in part during the COVID lockdown that I know caused some challenges. But what should we expect next? What secondary analyses and studies are you all planning?
So we are looking at predictors. So what was it? Were there any predictors from baseline variables that might have predicted outcome with treatment? So I can't really give too much away, but what I think I can say is that there are no variables or characteristics or clinical issues that alone should be seen to exclude people from receiving physiotherapy. So I won't say too much more about it, but like many of the other studies before that have tried to find predictors of outcome, they're much more elusive than you think they might be or than I thought they would be. We're doing some other secondary analyses which we hope to have published soon, looking at the difference between receiving treatment and not receiving treatment. So this is something that we're preparing at the moment, which I think will shed more light on the benefit of physiotherapy over nothing, but it might also help us understand the impact that COVID lockdown had on our trial.
We appreciate the preview. And so going back to the implications of this present study, as we think now in August 2024, what's the current role for physiotherapy in functional motor disorder?
So certainly I think it should be considered for patients with functional motor symptom because it appears safe. It's something that our patients want and they rate as helpful. And we have some evidence that it improves a range of health domain, although we unfortunately didn't find the evidence that the specialist approach was significantly better than usual physiotherapy approach. I think another way to look at that is that you don't need the specialist physiotherapy approach. So treatment within community teams that are less specialized but probably have some understanding of F&D can also be very valuable for people with F&D. And also, of course, physiotherapy should be considered as part of multidisciplinary treatment. We provided a short duration intervention and then followed patients up over 12 months. And if you think about the symptom duration of the participants in our trial, it was around about 4 to 5 years on average. And to expect that to be substantially different after our 9 sessions in our specialist physiotherapy group is a big ask. So I think we need to be thinking about longer term treatments and also, of course, multidisciplinary treatments to think about ways that we can address many of the complex problems that people with F&D often have.
Well said, Glenn. And you've given us a preview, too, to think about what potential future clinical trials, including the role of multidisciplinary interventions, might be in the horizon for this population. I want to just take a step back. Given your expertise in neurophysiotherapy, I find that a lot of important focus in neurology and in patients with complex brain-based disorders are in thinking about medication interventions and device intervention. But you've put a really nice spotlight on physical rehabilitation trials here. Can you say a little bit more about the importance of this in neurology?
Yeah, I think physical rehabilitation trials, and I'm sure the same is probably true for other forms of therapy, psychological therapy, speech therapy, occupational therapy, they're complex interventions, which makes them very difficult to study. So a drug trial, generally the outcome is easier to assess. We have an expectation of how a drug is going to work, and it's generally perhaps by one main mechanism. But complex interventions like physiotherapy can work through lots of different mechanisms of change. So they're much more challenging to do, to assess and design. And so I think that's perhaps one of the reasons why we don't have as many rehabilitation trials as we should have. But we do need evidence for these treatments. We need evidence to really inform our treatment triage decisions so we can direct patients to the treatment that's most likely to help them. And also to think about how to better use our limited and expensive resources, how we can improve that efficiency of resource use. I think they're really important, actually, but because they're more challenging to do, perhaps they're neglected a little bit.
Including this notion of precision medicine, which includes precision rehabilitation interventions as well. Another big picture question here, Glenn. You and I know each other given our participation in international societies and this kind of. And for those who are less familiar, you spend a lot of time clinically, research-wise, on educational initiatives in functional neurological disorder. Why is this a worthwhile path to pursue?
It's a worthwhile path because there's an enormous number of people with very significant and substantial problems, and many of them can really benefit from simple interventions or interventions such as physiotherapy. So it can be a real joy to work in this area. Our patients are really thankful for our time, and we can make big differences in their lives. In terms of research, 10 years ago, it felt a bit like a blank canvas, but now we're seeing a bit of momentum developing behind the research, but there's still a lot of research questions that need to be answered, clinical research questions as well. So I think there's just a lot of room to get involved. I think probably one of the things I like most about it are the other incredible people who work in this field. And when you go to an international meeting or a conference with F&D, it really feels like meeting up with friends. So it's a great area to work in, David. But I'm interested to know why you ended up being involved in research and having a special interest in F&D as well.
Functional neurological disorder sits at the intersection of neurology and psychiatry. I think it challenges how we conceptualize physical health and mental health. And when we think about the therapeutic effect sizes here, it can be so striking for those that benefit from the treatments that are available. I think we're humbled that not everyone improves, and so there's a lot of work to do. And then your earlier comments around thinking about the neuroscience and mechanisms implicated in functional neurological disorder are incredibly interesting as well. And so I would probably highlight those as most relevant in my own personal journey with this work. Glenn, as we wrap up, any final comments or take-home points from your Physio 4 functional motor disorder trial?
I think if you're a clinician who is interested in working in the area of F&D, I would say get involved because it's an area where there's a lack of resources for people with this problem, and you can make a substantial difference in their life. And we've got a growing body of evidence to support that. But also, if you're interested in research, this is the area to get involved in as well.
Glenn, a wonderful conversation. Thank you for joining us today.
Thanks very much, David.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.